Welcome to the deep dive. Today, we're jumping into pharmacology. We've got this really comprehensive study guide, and our mission. It's to pull out the absolute must-knows, the surprising bits, the stuff that's actually practical. Think of it like your shortcut to getting smart about meds you hear about, maybe even meds you take.
Exactly, because pharmacology, it's more than just names. It's the how and the why.
Yeah.
Why this dose? Why this warning? It matters for safety, for whether the drug actually works well. So yeah, we're cutting through the noise, aiming for insights that are clear and hopefully memorable.
Okay, let's dive right in. Segment 1. Precision in dosing and application when the details truly matter. We'll start with skin stuff, dermatology. Topical treatments here, strength and location are just key. So topical steroids, they've got these like 7 classes of strength. Class I is super potent, think clobetasol. That's for really thick skin, palm soles or severe conditions. Then you've got class 7, the mildest, like hydrocortisone, 1%. That's for thin skin face, eyelids, groin areas.
Right. And the why there is fascinating. It's all about absorption.
Ah, okay.
Thin skin just soaks things up more easily.
Yeah.
So using a super strong steroid on your face, that's a recipe for problems like skin thinning, atrophy, or even the drug getting into your system.
Right, so it's not just a suggestion, it's a safety thing. Location.
Restless.
Okay, another big one in dermatology, oral isotretinoin. People might know the old name Accutane for severe acne. Works by shrinking oil glands, controlling skin cells. But the massive point, the unmissable one.
Teratogenic.
Yeah.
Highly teratogenic.
Meaning birth defects, right? Severe ones.
Absolutely severe,
Yeah.
which is why we have the I Pledge program.
Yeah.
Mandatory. We're talking 2 forms of birth control, monthly pregnancy tests for anyone who could become pregnant. It's a really stark reminder that some meds carry risks so profound, these strict safety nets are just non-negotiable.
Wow. Okay, moving from what to when. Sometimes timing is everything. Antivirals, for instance, those drugs ending in thin-super. For things like herpes simplex, shingles, chickenpox, the rule is you've got to start them fast. Within 48, maybe 72 hours of symptoms showing up.
Yeah, that window is critical.
If you wait longer, the virus has already multiplied too much, and the drug just won't do much good. Oh, and a quick heads up. They can be kind of harsh on the kidneys. Renal toxicity is something doctors watch for.
And that timing thing, it makes perfect sense biologically. The antivirals stop the virus from copying itself. They work best early on before there are millions of copies. After that point, it's much harder to make a difference. It really is a race.
Makes sense. And briefly, those azole antifungals, ending in a azole. For yeast infections, athlete's foot. Key things there are potential liver hepatotoxicity, and they can mess with a lot of other drugs. Big interactions.
Yeah, the CYP450 enzyme system, they can really throw a wrench in how other meds are processed.
So knowing these details helps you understand the why behind the prescription. Okay, let's shift gears. Navigating the nervous system and moods, balancing efficacy with safety, starting with anticonvulsants, valproic acid or Depakote. Used for seizures, bipolar, even migraine prevention. It works well, but the side effects list is significant. Potential liver damage, pancreatitis, low platelets.
And again, the big one, teratogenic.
Right. Neural tube defects. Huge risk in pregnancy, so it's avoided.
It really underscores how patient factors like pregnancy completely change the risk-benefit calculation. What works for one person might be dangerous for another.
Okay, what about topiramate or Topamax? Also for seizures and migraines. People sometimes call it Dopamax because of that cognitive side effect, like word-finding trouble. Also risks of kidney stones and tingling, paresthesias. And again, avoid if you've got kidney stones or during pregnancy.
Yep, another one with teratogenic risk.
And just quickly, phenytoin, Dilantin. Known for its very narrow therapeutic range. Needs careful monitoring. Side effects like swollen gums, that serious SJS rash. And it can make birth control pills less effective. Barrier methods needed.
That narrow range is key. Too little, it doesn't work. Too much, it's toxic. A constant balancing act.
Okay, pivoting to something super common, migraines. Triptans, like sumatriptan, are often the go-to for stopping a migraine in its tracks. Abortive therapy.
Right, you take it right when the migraine starts.
But, and this is a big but, they constrict blood vessels. So absolutely contraindicated if you have coronary artery disease, history of stroke, or uncontrolled high blood pressure.
Exactly. The vasoconstriction helps the migraine. But it's dangerous if your blood vessels are already compromised, could trigger a heart attack or stroke.
Yeah, serious stuff. And a practical tip, don't overuse them more than, say, 2 days a week. You risk rebound headaches where the medication itself starts causing headaches.
Vicious cycle.
Okay, mental health, depression, anxiety. SSRIs are usually first line. Drugs like escitalopram, sertraline, fluoxetine, key thing.
Yeah.
They take time, like 4 to 6 weeks for the full effect. Don't expect overnight results.
Yeah, managing that expectation is crucial for adherence.
Side effects can be tricky. Sexual dysfunction is a big one, GI upset, sleep issues, weight changes maybe, and the really critical warning, increased risk of suicidal thinking in adolescents, especially when starting or changing dose, needs close watching.
That delay in effect, it's because they're gradually changing brain chemistry, rebalancing serotonin. It's not an instant fix like some other meds.
Now, compare SSRIs to older antidepressants like TCAs, tricyclics, amitriptyline, for example. They work, but they're dangerous in overdose because of heart rhythm problems. Need an EKG check beforehand, and not great for older folks due to those anticholinergic effects, confusion, dry mouth, constipation, falls.
Right, the side effect profile is much rougher, generally.
And then MAOIs like phenelzine for really tough depression. But that major warning about tyramine food.
Oh yeah, the cheese effect. Aged cheese, cured meats, red wine. Mixing those with MAOIs can cause a hypertensive crisis. Dangerously high blood pressure.
Okay, anxiety meds. Benzodiazepines, the POMs and LAMs, lorazepams, alprazolam, good for acute panic or anxiety. Quick relief.
Very effective short term.
But the downsides, sedation, confusion, falls, especially in the elderly. And the big ones, dependence, withdrawal risk, and extremely dangerous if mixed with opioids or alcohol risk of stopping breathing.
Absolutely. That's why they are not first line for chronic ongoing anxiety. SSRIs or SNRIs are preferred for that. It's a critical distinction. Acute relief versus long-term management.
Got it. Okay, let's move to the heart and lungs. The heartbeat and breath of life maintaining core functions.
Right.
ACE inhibitors, ending in probrol, like lisinopril. Great for blood pressure, heart failure, kidney protection, and diabetes. But they have that signature side effect.
The cough. That dry, annoying cough. It's from bradykinin buildup. Doesn't happen to everyone, but when it does, it's often why people stop the drug.
Right. And the more serious, though rarer one, angioedema. That's severe swelling.
Which is a medical emergency.
Sure.
Can affect the airway. Needs immediate attention.
And like we said before, absolutely contraindicated in pregnancy.
Yep.
Teratogenic. Quickly on diuretics. Thiazides, like hydrochlorothiazide. Often good first choices, especially for African American or older patients. But you gotta watch electrolytes. Low potassium, low sodium, and can increase calcium, uric acid, so caution with gout and blood sugar.
Lots to monitor there.
Beta blockers, ending in olol. Metoprolol, propranolol, used all over, BP, heart disease, heart failure, arrhythmias, even migraines. But a really key safety point for diabetics.
They can mask the symptoms of hypoglycemia.
Exactly. Someone's blood sugar could be dropping dangerously low, but the beta blocker hides the usual warning signs like rapid heartbeat or shakiness. Very important to know.
Critical piece of patient education there.
Now, a classic heart drug, digoxin, lanoxin. For heart failure, controlling rate, and atrial fibrillation. It's known for having a really narrow therapeutic window.
Extremely narrow. The difference between a helpful dose and a toxic dose is small. Needs very careful monitoring.
Toxicity signs, nausea, vomiting, those classic visual changes like seeing yellow halos around lights, and heart rhythm problems.
And here's a crucial link. Low potassium hypokalemia dramatically increases the risk of digoxin toxicity. So, electrolyte balance is vital when someone's on digoxin. There is an antidote, digibind, but prevention is key.
Okay, quick relief for angina, chest pain, short-acting nitrates like sublingual nitroglycerin. Under the tongue, the instructions are specific.
Yeah.
Take 1 dose. If pain isn't better in 5 minutes, call 911. You can take up to 2 more doses 5 minutes apart while waiting.
Crucial instruction.
And the absolute DO, not duo.
Don't take it with PDE5 inhibitors, Viagra, Cialis, Levitra.
Right. Why is that combo so dangerous?
Both drugs cause vasodilation, widening of blood vessels. Nitrates mainly affect veins, reducing heart workload. PDE5s affect arteries systemically. Put them together, and blood pressure can plummet catastrophically. Severe hypotension, shock, even death. It's an absolute no-go.
Got it. Lipid lowering. Statins, the prostastatins, atorvastatin, rosuvastatin. Workhorses for lowering LDL cholesterol. Main things to monitor are muscle breakdown, rhabdomyolysis, and liver function.
Muscle pain is something patients should report.
Okay, blood thinners, anticoagulants, warfarin, long-term use for AFib, mechanical valves, DVT-PE. Requires that constant INR monitoring. Target is usually 2 to 3, maybe 2.5 to 3.5 for mechanical heart valves.
Very precise range.
And again, contraindicated in pregnancy, antidote is vitamin K. We need specific INR guidance too. Like if INR is 510 without bleeding, you hold doses. If there's bleeding or it's over 10, you might need vitamin K.
Right. The management depends heavily on the actual INR level and whether the patient is actively bleeding. It's complex.
Contrast that with the newer ones, the DOAC's direct oral anticoagulants, apixaban, rivaroxaban, the big advantage.
No routine INR monitoring needed. Huge convenience factor.
Yeah, a game changer for many patients. Okay, shifting to breathing. Respiratory meds. LeMay, the long-acting muscarinic antagonist, often end in orchium, like tiotropium, used for COPD. They have those classic anticholinergic side effects. There's a mnemonic.
Yeah, can't see, can't pee, can't spit, can't poop. Basically blurred vision, urinary retention, dry mouth, constipation.
Good to remember. Okay, inhaled corticosteroids, ICS. The cornerstone for asthma control. Simple instruction after using.
Rinse your mouth out with water.
Why?
To prevent oral thrush, that yeast infection in the mouth. Simple step, big difference.
Nasal decongestant sprays like Afrin, oxymetazoline. The warning.
Don't use them for more than 3 days.
Because...
Rebound congestion, rhinitis medicamentosa. Your nose gets even stuffier when you stop, making you want to use more. Easy trap to fall into.
Right. And finally, cough suppressants, antitussives, especially those with codeine. Avoid in young children, right? Under 6.
Definitely. Risk of respiratory depression. Their breathing could slow down dangerously.
Okay, that covers a lot of ground. Let's move into metabolic mysteries and reproductive insights.
That's good.
Endocrinology. Diabetes first. Metformin. It's usually the starting point. Works by reducing liver glucose production, increasing insulin sensitivity. Big pluses.
It doesn't cause hypoglycemia on its own, which is great. It's often weight neutral or can lead to modest weight loss. And it has known cardiovascular benefits.
Right. Main side effect is usually GI upset, diarrhea, nausea, especially when starting. Need to watch kidney function, though. Can't use it if GFR is below 30, and hold it before contrast dye procedures. Also, long-term, maybe a risk of B12 deficiency.
Important points. It's still a fantastic drug, but needs that monitoring.
Now, the newer classes, SGLT2, inhibitors, the plasensins, like empagliflozin, and GLP-1 agonists, the duptides, like semaglutide. These are really exciting because they do more than just lower sugar.
Absolutely. Major cardiovascular protection, major kidney protection, often significant weight loss. They've really shifted how we approach diabetes treatment, looking beyond just glucose control.
Are there specific watch-outs like SGLT2s and UTIs, GLP-1s, and thyroid cancer risk?
Yes. SGLT2s can increase risk of UTIs and yeast infections due to sugar in the urine. GLP-1s have a warning regarding a rare type of thyroid cancer, medullary thyroid carcinoma, so they're avoided in people with a personal or family history.
Good to know. Okay, thyroid hormone, levothyroxine, Synthroid for hypothyroidism. Patient education is key here. How to take it.
On an empty stomach. First thing in the morning, ideally 30 to 60 minutes before breakfast or any other medications or coffee.
And definitely separate from certain supplements.
Yes, calcium and iron especially. They bind to levothyroxine and prevent absorption. Need to space them out by several hours.
And long-term risks if the dose is too high, osteoporosis, atrial fibrillation.
Right, mimicking hyperthyroidism essentially.
Okay, GI tract, PPIs, proton pump inhibitors, the hyperzoles, omeprazole, pantoprazole. For GERD, ulcers, best taken when?
About 30 to 60 minutes before the first meal of the day works best for most people.
We hear a lot about long-term risks now. What are they?
Yeah, it's become a bigger focus. Long-term use is linked to B12 deficiency, low magnesium levels, increased risk of osteoporosis and bone fractures, and importantly, increased risk of C. diff infection.
C. diff, that nasty gut infection. So PPIs aren't necessarily benign for indefinite use.
Exactly. The goal should always be the lowest effective dose for the shortest necessary duration. Reevaluating the need for them periodically is important.
Anti-nausea meds, ondansetron, Zofran, can cause QT prolongation and heart rhythm issue. Promethazine, Phenergan, has that boxed warning.
Yes, serious risk of respiratory depression in children under 2 years old.
Yeah.
Should not be used in that age group.
Metronidazole, Flagyl. We mentioned it for infections like BV, trichomoniasis, C. diff. The one huge thing to remember.
The reaction with alcohol. Disulfiram-like reaction, severe nausea, vomiting, flushing, headache, absolutely no alcohol while taking it and for a few days after.
Got it. And loperamide, Imodium for diarrhea. When should you not use it?
Avoid it if there's bloody diarrhea or a high fever. Could indicate an invasive bacterial infection, and slowing down gut motility might worsen things, potentially leading to toxic megacolon.
Okay, reproductive health. Combined oral contraceptives, COCs, birth control pills. Who shouldn't take them?
Key contraindications include smokers over 35, anyone with a history of DVT or PE, blood clots,
Mm,
stroke, migraine with aura, uncontrolled hypertension, or history of breast cancer.
because of the estrogen risk, right? Clots.
Primarily, yes. And for breastfeeding individuals.
Progestin-only methods are preferred. Pills, IUDs, implants. Estrogen can decrease milk supply and still carries that clot risk postpartum.
Right. And knowing what to do if you miss pills is also key. The advice differs if you miss 1, 2, or 3 or more.
Erectile dysfunction meds, PDE5 inhibitors,
Yep.
the Asfil, Sildenafil, Viagra, Tadalafil, Cialis. We already hammered the nitrate contraindication. What else?
Cardiac clearance is often recommended before starting them. ED itself can be an early warning sign of underlying cardiovascular disease. So it's not just about treating the ED, but checking the heart health too.
Interesting connection. Musculoskeletal stuff briefly. Bisphosphonates for osteoporosis.
Okay.
Dodronates, like alendronate, specific instructions for taking these.
Yes, crucial for safety. Take with a full glass of plain water first thing in the morning on an empty stomach, and you must stay upright sitting or standing for at least 30 minutes afterward.
Why stay upright?
To prevent severe esophageal irritation or ulcers. The pill can get stuck and cause damage if you lie down.
And there's talk of a drug holiday.
Yes. For lower-risk patients, after about 5 years of oral therapy or 3 years of IV therapy, stopping for a period might be considered to reduce long-term risks, like atypical femur fractures.
NSAIDs, like ibuprofen, naproxen, we know the risks. GI bleed, ulcers, kidney problems, increased cardiovascular risk. But for older adults with arthritis in knees or hands?
Topical NSAIDs, like diclofenac gel, are often first line. Less systemic absorption means fewer systemic side effects, which is safer, especially in the elderly.
Makes sense. And gout treatment. Allopurinol is for.
Prevention, chronic management, lowering uric acid levels over time.
But you don't start it during an acute flare-up.
Correct. Starting it then can actually worsen or prolong the flare initially. You treat the acute attack first, then consider starting allopurinol later.
And for the acute attack?
NSAIDs are usually first line, or colchicine, especially if started within 24 hours. Colchicine's main side effect is GI upset, particularly diarrhea.
Okay, final stretch. The world of antibiotics targeting invaders with care.
Let's do it.
Penicillins, amoxicillin, common for strep throat, ear infections, syphilis. Allergy is common, and there's some cross-reactivity with...
Cephalosporins.
Yeah.
About 10% chance. So caution is needed if someone has a true, severe penicillin allergy.
Cephalosporins themselves, they have generations, right? Up to 5th gen?
Yeah, they get broader in coverage. The 5th gen one, ceftaroline, is notable because it covers MRSA.
Okay. Tetracyclines, like doxycycline, used for acne, chlamydia, Lyme disease. What are the key patient instructions?
Avoid taking with dairy products, antacids, or iron supplements. They decrease absorption. Take with a full glass of water and stay upright for a bit to avoid esophageal irritation.
And the really big contraindication?
Pregnancy in children under 8 years old.
Because?
Permanent staining of developing teeth and potential effects on bone growth. Really important one to remember.
Fluoroquinolones, the floxacins like Cipro, Levaquin, known for some serious side effects.
Yes, the big ones are QT prolongation, which affects heart rhythm, and the risk of tendon rupture, particularly the Achilles tendon.
Tendon rupture. Wow. So patients need to report tendon pain immediately.
Absolutely. Stop the drug and report it. Also, generally avoided in pregnancy and children due to potential cartilage damage shown in animal studies.
Vancomycin, used for serious stuff like MRSA and the oral form for C. diff. Side effects.
Kidney toxicity, nephrotoxicity, hearing loss, odor toxicity, and that distinctive red man syndrome.
Yes, red man syndrome. That's from infusing it too fast.
Yeah, exactly. It's a histamine release causing flushing, itching, rash, mostly on the upper body. Not a true allergy usually, but requires slowing the infusion rate way down. Monitoring trough levels and kidney function is standard.
And rifampin for tuberculosis. The memorable side effect.
Turns body fluids urine, sweat, tears a harmless red-orange color. Looks alarming. The patients need to be warned. It's expected.
Phew. Okay, we have covered an incredible amount of ground, taking that dense pharmacology guide and really pulling out the crucial, practical insights.
We really did. It's a lot. But hopefully breaking it down this way helps connect the dots.
Yeah, I hope you listening feel like you've got a better handle on these meds now. It's not just names. It's the how, the why, the benefits, the risks, those surprising connections.
Absolutely. And that knowledge really is power. It helps you ask better questions, understand your treatment plan, and just appreciate the science behind it all. It's about having more informed conversations about your health.
So here's a thought to leave you with. How does understanding this intricate dance, the timing, the risks, the way these drugs interact with different parts of your body, how does that change how you think about medicine or how you talk about health with your doctor or even with friends and family?
Yeah, something to think about.
Definitely. Keep that curiosity alive, and we'll catch you on the next deep dive.